Good morning all. Today we are going to take a class on Pityriasis rosea. Before going to that, I introduce myself Dr. Govardhan. I'm professor in Department of DVL, Sri Lakshminarayana Institute of Medical Sciences, Pondicherry. Okay, Pityriasis rosea. Today we are going to cover our topics under the following headings, like definition, history of the disease, epidemiology, predisposing factors, etiology, clinical features, its histopathology, clinical variants of Pityriasis rosea, differential diagnosis, what are the complications and comorbidities, what is the course of the Pityriasis rosea, what are investigations, means how do you diagnose it, and treatment aspect we will discuss. Coming to what is Pityriasis rosea? Pityriasis rosea is an acute self-limiting papillosquamous disorder. Probably it's infective in origin. Most commonly it affects the teenagers and young adults, and it will be having minimal constitutional symptoms and it will last for about 4 to 10 weeks duration usually. Coming to the history, P. rosea means pink scales. The meaning of it is pink scales. Okay, first it is reported in an Edinburgh dermatologist by Dr. Robert Villan in 1798. The term Pityriasis rosea is coined by French dermatologist Dr. Camille Guibert in 1860. Pityriasis rosea is having few synonyms like Pityriasis sarcinata et maculata of Weddell, Roseella annulata, Erythema annulatum. So coming to the epidemiology, the annual incidence of Pityriasis rosea is around 170 per 1 lakh persons. Peak incidence it occurs in the winter season. Usually it occurs in other seasons also. So cause of this Pityriasis rosea is uncertain. Usually it's suggestive of infective etiology due to its resemblance to viral exanthems, lesions, and rare recurrences, which is suggestive of lifelong immunity. And clustering in the communities will be there. Seasonal variations is seen and associated with flu-like symptoms. What is the natural history of Pityriasis rosea? Usually it starts with a primary lesion. It's called a nether patch. You can see in this picture. And after a few days, disseminated secondary eruption after an interval of 3 to 5 days or little more may be seen, usually associated with mild constitutional symptoms, which is having self-limited course, and secondary attack is usually infrequent. This suggests lifelong immunity. Most commonly, it affects 10 to 35 years of age, and it's seen very rarely in less than 2 years of age and also more than 65 years of people. Most commonly, it is seen in the females than males in the ratio of 1:5:1, and race and ethnicity is not affected for this disease actually. What are the predisposing factors? Predisposing factors are reduced immunity like immunosuppressive conditions, long-term oral corticosteroid therapy, bone marrow transplantation people which having again immunosuppression, and pregnancy, similar conditions which any chronic stress to the body, trauma like that, all these are, and few drugs also predisposed to the Pityriasis rosea. Few of the drugs which causes Pityriasis rosea are angiotensin converting inhibitors and arsenic compounds, barbiturates, bismuth, beta blockers, clonidine, meprobamate, captopril, griseofulvin, gold salts, isotretinoin, imatinib, interferon, ketotifen, metronidazole, terbinafine, penicillins, NSAIDs, and omeprazole, vaccines like BCG, diphtheria toxoid, pneumococcal vaccine, hepatitis B, and multiple few other drugs also can cause pityriaciform drug eruptions. So we should not get confused. Few of the drug history is important to take in Pityriasis rosea infection if you see. So what is the etiology of Pityriasis rosea? 71% of the Pityriasis rosea patients have herpes virus-like particles in this. Like most commonly extracted are HHV7, that is human herpes virus 7, and then human herpes virus 6. Herpes virus 7 is most extracted than HHV6. So definitive study by Broccolo and colleagues in 2005 showed HHV7 and less commonly HHV6 DNA, mRNA, protein, and specific IgMs. And HHV7 and HHV6 DNA are also been extracted in saliva of the people also. Even other viruses like human herpes virus 8, herpes simplex virus 2, hepatitis C, H1N1 influenza, Legionella, few of the other etiological agents have been proposed for causation of Pityriasis rosea. Then coming to the clinical features, what are the clinical features? So usually there is no prodromal symptoms, and most commonly to start with, the flu-like symptoms will be there, and it starts as a herald patch. It's also called mother patch. So usually that is the first manifestation, and usually it occurs only one lesion, and usually it is large and more conspicuous. Most commonly it occurs in the thigh, upper arm, trunk, and neck, and which is sharply defined erythematous salmon colored, that's pinkish colored, round or oval plaque covered by fine peripheral collet of scales, which I'm going to describe in the next slides. And this plaque is usually 2 to 5 centimeters in size. Occasionally much larger also, maybe smaller also. Rarely more than one herald patch may appear. And herald patch, which occurs 80% of the people will having herald patch. Sometimes 10 to 20% of the people will not have herald patch. So in this picture, you can see the typical herald patch, single salmon colored, well-defined erythematous means herald patch. So round, and we can see collet of scales. Collet of scales is scales you can see as a collar line attached in the periphery. This is called collet of scales. Same thing is depicted in the diagram also. Okay. So after 2 days to 2 weeks of this herald patch, usually 3 to 5 days or maximum 1 week it will take. Will give ranges 2 days to 2 weeks. There is a general eruption begins to appear over the all over the body, maybe, and may continue for several weeks also. It may take few days also, several weeks also. New eruptions may come. So there are two types of Pityriasis rosea. One is classical form, and other is small red non-scaly papules. Classical form, discrete small plaques resembling the primary plaque may be seen, or erythematous papules or plaques may be seen, and other is small red non-scaly papules may be seen. So the center of the lesion tends to clear and assumes a wrinkled atrophic appearance with marginal collet of scales. So I have already explained what is collet of scales. So marginal collet of scales we will see. So if you see in this picture, this is called Christmas tree pattern of the upper back and chest. Here you can see this multiple erythematous salmon colored papules and plaques which are distributed along these lines over the back, which is giving an appearance of Christmas tree pattern. And also if you see individual herald patch, we'll see the collet of scales. When you stretch this herald patch or these lesions along the long axis, the scales tend to follow the line of stretch. So this is called hanging curtain sign. Hanging curtain sign means it is these scales are attached at the periphery and which is free towards the center. So this is called hanging curtain sign. So similarly, you can see the long axis of the lesion which all follow the cleavage, lines of cleavage of parallel to the ribs. So if you see the ribs, lines of cleavage, we stretch the lesions, the skin lesions will follow the cleavage parallel to the ribs. Okay. So this is one of the clinical picture which is showing in the lower trunk herald patch followed by multiple diffuse erythematous daughter lesions or other lesions of the Pityriasis rosea in the trunk upper limbs. So what are the most common sites of these lesions? So mainly it affects the trunk, base of the neck, upper 1/3 of the arms and legs. So other few other areas, means rare areas, are not always common. Rarely you can see over the face, scalp, forearms and legs, which may be quite commonly involved. Palms and soles are rarely involved, very rarely. I mean, it's exceptional, very rarely involved. Oral and vaginal mucosa lesions are very rare. Still, they have reported, very few cases have been reported. 6 to 12% of the people will have inverse distribution in only they will have lesions only over the forearms and lower legs. They don't have lesions over the trunk and trunk, head and neck, other areas. They will have lesions only over forearm, legs. So this is called inverse distribution. This is called inverse type of Pityriasis rosea. This is one of the other picture schematic diagram. Is so primary patch, that is means herald patch over the upper back, you can show in the picture, and also other typical distribution of the secondary plaques along the line of cleavage on the trunk, which is giving a Christmas tree pattern. This is the back, this is the front lesions. So lesions you can see over the upper back, trunk, thighs, back of the thighs, arms. Similarly, front also, chest, trunk, thighs, arms. So usually it is associated with other constitutional symptoms. Mild constitutional symptoms means flu-like symptoms like slight moderate pruritus. Lesions are associated with pruritus. fever, malaise, lymph node enlargement, rarely you can see, headache, nausea, loss of appetite, arthralgia, and sometimes sore throat also may be seen. So coming to the histopathology of the Pityriasis rosea. Even though histopathology of the Pityriasis rosea is non-specific, few lesions, few of the findings, if you see, you can that lead to the easy for the diagnosis for the clinician. Okay, what are the few common features we'll see in the histopathology? As you see in the picture, you'll see in the parakeratosis. That means retention of nuclei in the stratum corneum. It's called parakeratosis. And second feature is in the epidermis, spongiosis and mild lymphocytic exocytosis. Spongiosis, intercellular edema, spongiosis with mild lymphocytic exocytosis. Lymphocytes are present in the epidermis. Psoriasiform hyperplasia, acanthosis and hyperplasia of the lesions, which gives a psoriasiform hyperplasia. So these are the findings in the epidermis. Coming to the dermis, there is superficial perivascular lymphocytic infiltrate, as you see in this picture, superficial perivascular lymphocytic infiltrate, and few in the other area parts of the dermis are also present. Most specific feature here is red cell extravasation, means extravasation of RBCs. You can see very clearly over the in the dermis. Okay, reddish things, these are the RBCs. You can see extravasation of RBCs is also seen in the dermis. These features which help to diagnose the Pityriasis rosea. So then coming to the clinical classification of Pityriasis rosea. Clinically, Pityriasis rosea is classified based on the herald patch, based on location of the lesions, and based on the type, means morphology of the lesion. Three classification is given. Based on the herald patch, means different types of herald patch. Sometimes herald patch may be absent herald patch. Sometimes only herald patch will be present, and multiple herald patches may also be present. Herald patch in atypical location means we will not see in the forearm, hands, so feet, all these things are atypical location, because most commonly we will see over the neck, trunk, neck, then thighs, arms. These are the areas, common areas. So in atypical locations like forearms, arms, feet also you can be seen. This is based on the herald patch. So then based on the location of the lesions, like lesions limited to the scalp, lesions limited to trunk also, lesions limited to limb girdle, means which is called Pityriasis ursinata, H, marginata of pedal. Then limited to the flexures and extremities, Pityriasis inversa. As we already discussed, lesions are absent all over the body except over the forearms, hands, and legs and feet, something like this, called Pityriasis inversa. So then acral type, only hands and feet are involved. This is called acral type of the lesions. And along the lines of Blaschko, so Blaschko we have showed already in the picture previously, following the lines of the Blaschko. Then unilateral means one part of the body is only involved, other part is not there. This is called unilateral distribution. So this is the one of based on the location of the lesion. Then coming to the based on morphology of the lesion. Morphology means type of lesions. Most commonly we will see papillar and plaque type of lesions most commonly. Then other vesicular type of lesions may also be seen. Then follicular means hair lesions over the hair follicles. Lesions also may be seen. Then purpuric or hemorrhagic lesions. Purpura means extravasation of RBC. You will see erythematous lesions which do not go off when you press this. It is called purpuric lesions or hemorrhagic lesions. Then urticarial lesions means hives are present. Urticarial lesions also. Then erythema multiforme like. Erythema multiforme means target type of lesions that we are going to show in the future slides. So these are based on the morphology, different types like papillar, vesicular, follicular, purpuric or hemorrhagic, urticarial, erythema multiforme like lesions are seen. So this picture, one of the shows the this herald patch over the left sole. If you see left sole, herald patch is seen. This is the unusual site of the herald patch, what you can see in this picture. So multiple herald patches which coalesced, we can see over the lower part of the trunk in the sea. You can see central part is clearing and the peripheral scales are there. So multiple herald patches which joined or coalesced together. Okay. These two pictures shows the acral Pityriasis rosea. Acral means periphery or hands and feet areas. So in this area, small baby having the feet, upper part of the feet having these scales, collet of scales. You can see these lesions, P rosea lesion. Similarly, in this wrist area, you can see erythematous plaque with collet of scales very clearly. So this is acral Pityriasis rosea. This is one of the rare things also, and very good. You got good pictures. So this first picture, which shows erythema multiforme like Pityriasis rosea. Erythema multiforme means usually it occurs in the drug reactions. Any drug reaction, cutaneous lesions will be erythema multiforme like. Similar type of morphological lesions we also will be encountered in the pityriasis rosea lesions sometimes. So target type of lesions, we say target means central you can see grayish color vesicle or a papule or a vesicle, then surrounded by erythematous halo, then hypopigmented erythematous halo you can see. This is called target lesion. So this usually you will see in the erythema multiforme. Erythema multiforme like lesions also may be seen in the pityriasis rosea. And right side picture depicts the multiple erythematous papules. This is called papular P rosea. All over the body may be there. Only one part of the picture is present here. Okay, this picture if you see very clearly, vesicular pityriasis rosea. Vesicle means well-defined erythematous raised skin lesion with fluid filled with the fluid. This is called a vesicle. So multiple vesicles you can see almost all over the body. Upper limb you can see, chest, trunk, all over the body you can see. This is called vesicular PR. PR is presenting in a different form, so it's very difficult to diagnose sometimes. Sometimes this is looking like even hands and syphilis. So many things. We'll coming to the differential diagnosis. We'll tell other lesions also. This is it's looking like mimicking other lesions also. So this is, but if you see clinically and also histopathologically, if you see its course, then we'll diagnose it as a vesicular PR. Follicular PR. Follicular, as I already told, see in the hair follicles. See, if you see very clearly surrounding these lesions, hair follicles only are involved in this condition. So it's called follicular pityriasis rosea. And you see, if you see back side, it's giving a little bit Christmas tree pattern. So if you see very clearly, okay. So follicular pityriasis rosea, this picture. Similarly, this picture shows a gigant of barrier. That means all big, huge lesions. See, if you see very huge plaques which are coalesced, means joined together, means multiple diffuse erythema with fine scaling. You can see here. Only if you see small lesions and do biopsy only, you can diagnose. Otherwise, it may be giving, it is mimicking different diseases like syphilis, psoriasis also you can think, pityriasis rosea, pityriasis rubra pilaris, many other differential diagnosis you can see. But after doing histopathology, biopsy and skin lesions correlating them, will come to the diagnosis of pityriasis rosea. So this big, huge lesions and even barrier-like disease also you can see. Multiple crusting also you can see in the upper part and in the center also. So this is called pityriasis rosea, gigantea barrier. So as I already told, a few of the drugs which cause pityriasis-form drug eruptions. So similarly, you can see papules and plaques with colorate of scales you can see here. So similar, these kind of lesions are called by few of the drugs like ACE inhibitors, metoprolol. So many things I have listed previously, and few vaccines also, BCG vaccine, other vaccines also we listed. P rosea like lesions, drug eruption may also be seen. We should take a drug history importantly with the patients before diagnosing. Then coming to the what are the differential diagnosis means tinea corporis. Other different tinea corporis means herald patch. We always confuse with the tinea corporis. Tinea corporis also round to oval, well-defined erythematous plaque with scaling with the central clearing will be there. Here also central clearing will see, but very fine scales will be there. If you see in pityriasis rosea, colorate of scales are seen. Colorate of scales may not be present in tinea corporis, and tinea corporis will be hyperpigmentation may be there. And the peripheral activity will be there, few papules will be there, and itching will be severe in tinea corporis. Like this, we have to differentiate between tinea corporis. And drug reaction, already I have told, PR like drug eruption. In seborrheic dermatitis means dandruff like. So sometimes seborrheic dermatitis lesions also look like small papules and plaque type lesions over the upper part of the chest and the trunk. Means upper back also you can see. Then secondary syphilis. Secondary, as you all know, syphilis is a great mimicker, any type of lesion. I already showed one picture in vesicular PR like syphilis-like lesions. Syphilis can present with any type of lesions. An acute urticaria of the childhood. Urticaria lesions means hives can also be seen, like papular urticaria, vesicular urticaria-like lesions. We should not get confused. Then guttate psoriasis. Guttate means when you spray the water, the droplets will be seen. So multiple droplets seen over the trunk, front and back. It's called guttate type of lesion. Similarly, guttate psoriasis also present like this. Guttate psoriasis is one of the differential diagnoses. Then pityriasis lichenoides chronica. This is one of the chronic condition. This is then pityriasis versicolor is one of superficial fungal infection. The nummular dermatitis means one of the type of eczema. Here also round to oval oozing lesions, plaques are there. So like this, multiple differential diagnosis. You have to differentiate from each condition before diagnosing a patient with pityriasis rosea. What is the course of the disease? So usually it takes 6 to 8 weeks. It may long for 6 to 8 weeks, and it may resolve by itself without any treatment. Also, with the treatment, also it may resolve by itself. Also, it may take little bit more time. Also, sometimes you should always counsel the patient. Very important, and it may heal with temporary hypo or hyperpigmentation. Very rarely, in 2% of the patients, you can see recurrence. Very rare. Otherwise, usually you won't see. Then what are the complications? First trimester of pregnancies, the spontaneous abortion may occur, preterm labor may occur, child with hypotonia, hyporeactivity may also occur if it comes in the pregnancy. Then how to diagnose it? Coming to the investigations. Investigations already clinical. Clinically, if you see presentations, different types of presentation means most commonly it presents with a herald patch. So patient present with comes with a history of a big round or oval reddish lesion. After few days, means 2 to 5 days or 1 week or 2 weeks maximum, 2 to 5 days, all over the daughter lesions will be present. So if you take the history properly, so patient will give that history very clearly. Based on clinically only, you can diagnose. When you see the herald patch, there will a typical lesion, you will have collet of scales, white scales, which is adherent towards the periphery and free towards the center. So, and and we can also diagnose with the help of skin biopsy. Even though non-specific, I showed you in skin biopsy few of the findings which lead to the diagnosis of the Pityriasis rosae, like parakeratosis, then extravasation of RBCs. All these things will help in the diagnosis of Pityriasis rosae. Okay. Then coming to the treatment, how do you treat this condition? So usually these few lesions are symptomatic. Very rarely patients will have mild itching and flu-like symptoms will be there. Usually no treatment is required, self-limiting, but you have to explain to the patient its course. Sometimes it may take long time. But usually what we do, moisturizers will give, you can apply all over the body, and over the lesions, you can give mild topical steroids of moderate potency, so it helps in the reduction of the inflammation and redness will reduce. And even UVB therapy is also one of the best mode of treatment. Second line, what we use, oral acyclovir antiviral, since human herpes virus is implicated 7 and 6. Try to do herpes acyclovir antivirus like acyclovir 400 mg or 800 mg 5 times daily for 1 week duration. Also antibiotics like the tablet erythromycin 25 to 40 milligram per kg per day for 2 weeks will give. This not only helps in the treatment but also immunomodulation it causes. Likewise, it helps in the regression of the lesions. Then other treatment options which have been tried are emollients, as I told, and soothing agents like calamine lotion you can apply, and systemic antihistamines and corticosteroids. In severe kind of lesions, if they are there, you have to give systemic corticosteroids, short duration of systemic corticosteroids like prednisolone or methylprednisolone you can give. And if the patient is having the itching, we will give antihistamines. It's symptomatic, how many days you want, you can give. So by this we are completing. These are my references, like Rook's textbook of dermatology, Fitzpatrick, Andrews, IADL textbook of dermatology, and other few of the articles. Thank you.